Greetings everyone, my name is Dana Cirelli and my presentation is concerned with determining the impact of infant-driven or cue-based feeding of the preterm infant in the neonatal intensive care unit. The purpose of this research investigation is to determine if infant-based infant feedings or cue-based infant feeding results in a shorter transition from gavage feeds to full oral feeds than a volume-driven approach in the premature infant. To give you a brief history of the reason I selected this topic, I work as a staff nurse in the Level 3 NICU where we care for a number of premature infants, some as young as 24 weeks of gestational age. As you can imagine, those babies overcome a lot of obstacles and they really have a lot of challenges ahead of them. But as they grow and eventually they develop the ability to breast or bottle feed, and ultimately they will reach full oral status and discharge home with their happy family. They often have feeding problems, and there are a number of reasons for these problems, and every infant is different. One thing that remains constant is that infants of any gestational age require nutrition and must be fed according to their needs. Many preterm infants are started out receiving nutrition parenterally with the goal to begin gavage feeding and then progress to oral feeds as soon as they can tolerate. Traditionally, many neonatologists and nurse practitioners have ordered feeding to progress based on a volume-driven schedule where an ordered volume is delivered at a specified interval with no regard to the feeding cues of the infant. Statement of the problem. Oral feeding is a milestone for discharge for the neonate from the NICU. Premature infants frequently lack the ability to effectively and safely orally feed. Traditionally, NICU policies supported volume-driven feeding without regard for infants' readiness to feed. Failure to respond to infant feeding cues often results in an unsuccessful feeding experience for the infant, nurse, and family, and does not move the infant closer to full oral feeds or discharge from the unit. Many infants behave as if they have no interest in eating and should be gavage fed. They just need to sleep, and forcing them to breast or bottle feed will most likely result in a lack of interest on the part of the infant and disappointment or frustration on the part of the nurse. But one fine day when you lift that blanket up from the isolette, you will see cues. You'll see that tiny baby sucking his fist or rooting or maybe demonstrating some non-nutritive sucking, such as sucking on a pacifier. They may grab your finger, stick it in their mouth, try to suck on your stethoscope. Whatever their method of telling you, they are ready to be fed. That's when the nurse should suggest to the practitioner to introduce oral feeds to the infant. Now, this isn't always an easy sell. Some nurses are very comfortable and very much pride themselves on their ability to get that baby to eat. So, infant feeding cues aren't necessarily at the top of their priority list. And as usual, a different type of practice or a change in practice is sometimes met with some resistance. But the significance of this research study is that learning to read infant cues for hunger and fullness and responding to them appropriately allows the infant to direct the feeding according to his needs. And that babies fed on cue tend to consume more and achieve full oral feeds sooner than those who are fed based on a volume-driven schedule, and hopefully this will result in a decreased length of stay. Decreased length of stay and its resultant discharge to home is better for the infant and the family. I think we will all agree with that. The theoretical framework that I've selected for my research study is Levine's conservation model of nursing. I think it fits perfectly. with the challenges faced by the neonate and their family as they undergo constant change. The neonate is undergoing so many physiological changes. The family is learning to adapt with the unexpected event of having an infant in the NICU, and then the ups and downs and the roller coaster ride that baby will take them on for the next days, weeks, or months while they're a patient in the NICU. Levine's conservation model suggests conservation of energy, and specifically for the neonate, that conservation of energy allows the infant to sleep and grow physically and neurologically, which is so important for them. And it also provides for a holistic or speaks to a holistic approach to the neonatal family. So the holistic approach is the conservation of energy, which I've already said is so important for the baby. And then also keeping an eye on the structural integrity of the family, the personal integrity of the baby and the parents, and then the social integrity, the family unit, the extended family unit, support groups or support entities outside the family that can help support the family through this trying time. The goal is to achieve health or wholeness of the infant in the family system, and that's why it plays so well with the theoretical framework of Levine's conservation model of nursing works so well with the needs of the neonate. Research questions obviously are: does the cue-based feeding protocol result in decreased time to achieve full oral feeds? And the hypothesis is that feeding preterm infants based on their feeding cues does result in fewer days to full oral feeds and decreases the length of stay in the NICU. As far as definitions are concerned, the theoretical definitions of independent variable would be that the independent variable is feeding infants on cue, and the dependent variable would be the decrease in time to full oral feeds. Operational definitions include infant-driven feeding, which that I believe I've already said is defined as feeding that infant on cue. If he's not cueing, he gets gavage fed. If he is cueing, you feed him until he stops cueing or indicates to you that he is done. So that's infant-driven or cue-based feeding. Volume-based feeding is strictly feeding a baby a set amount based on caloric need, a volume of formula or express breast milk at a specific time frame or on a specific time schedule each day. And then full oral feeding is defined as that infant's ability to take 100% of his feeds orally via breast or express breast milk or bottle feeding or formula feeding each day. Assumptions of the study are that following feeding cues will result in decreased length of time to achievement of full oral feeds, and that initiating feeds when an infant is cueing will result in a safer feed. The infant won't choke, they won't have decreased heart rate, they won't have apneic episodes or vomiting. When the feeds are stopped when the infant cues that he's full or too tired to continue, gavage feeding allows the infant to conserve energy for the next feed. Teaching parents to recognize feeding cues also empowers them, makes them feel like they have a purpose. There's something that they can do to contribute to the care of their baby, and allows them to participate in their infant's care. Delimitations of the study are participants have to be preterm infants who are demonstrating feeding cues. They must be approved for PO feeds or bimouth feeds. They must demonstrate coordination of the suck-swallow breathing reflex, and they must exhibit alert-awake behavior. They can't be sleeping all the time. And they also must maintain cardiorespiratory stability. If they're not stable in that arena, they do not start PO feeds. Limitations of the study are the transition from volume-driven to cue-driven feeding can be difficult for some nursing staff. Nurses don't necessarily always respond favorably to change. This particular research study will be held in a single unit, although I believe that the patient census will support the study quite well. It will only represent the experience in one single unit. And then the other limitation is that families are not always available. Although they're allowed to visit whenever they want, they're not always able to visit during feeding times, and therefore they may miss those hunger cues. So, in other words, when they are able to show up for a visit and they want to feed the baby, if he's not cueing that he's ready to eat, they miss out on a feed, and that can be disappointing for them. The research design and subject type, I've selected an experimental design. My control group would be that the infant gets fed according to a volume-driven schedule, and the experimental group is the infant gets fed according to a cue-based schedule. The feeding starts and ends based on baby's cues. The participants must be approximately 32 to 34 weeks gestational age, corrected gestational age. And they must be cleared to oral feed, and they must exhibit feeding cues. Also, their parents must consent to have them as part of the study. As far as data analysis, the research question is, what is the effect on time to full oral feeds when cue-based feeding is initiated as appropriate? The level of measurement for each variable is as follows. Cue feeding schedule is the independent variable, and it will be an ordinal measurement. Full oral feeds is the dependent variable, and it will be a ratio measurement. The statistical method proposed would be chi-squared for both variables, possibly independent group or paired t-test. Thank you very much for your attention, and I look forward to your comments, and I also wish you the best of luck as you finish this course and in your future endeavors.